Welcome back, Focus Learners, to another explainer. Today, we're diving headfirst into something that honestly looks like a highly structured alphabet soup at first glance, the wild, intricate world of medical billing. Seriously, if you've ever stared at a medical bill and wondered, how on earth does human biology translate into these dollar signs? Well, you are in the exact right place. We're going to break down the core CPT basics, the coding rules, and the actual guidelines that make this hidden language work behind the scenes in literally every hospital and clinic. Let's get into it.
So, as of 2026, the American healthcare vocabulary contains exactly 11,520 distinct codes that providers can use to describe what they did to you. 11,520. I mean, that is a massive, highly specific language. Whether a doctor is just listening to your heart, performing a super complex brain surgery, or treating some unexpected complication, yep, there's a specific code for it. But you've got to wonder, how do they know which one to use? And maybe even more importantly, who actually decides what each of those codes is worth?
Well, here's our roadmap for today. We're going to hit Section 1, Decoding CPT Basics. Section 2, the math behind the code. Section 3, who writes the rules. Section 4, bending the rules with modifiers. And we'll wrap up with Section 5, two codes working together.
All right, Section 1, Decoding CPT Basics, Understanding the Language.
The absolute backbone of this entire system is CPT, which stands for Current Procedural Terminology. And you know what's really fascinating? It's not actually the government that owns or governs this language, it's the American Medical Association, the AMA. Providers use this specific set of 11,520 codes to report the professional services they provide. And it's not just for one specific type of doctor. These coding guidelines apply straight across the board, whether we're talking about an inpatient hospital ward, an outpatient clinic, a private practice, or an ancillary care setting. It's basically the universal language of medical effort.
But, okay, here's where the coding rules start to get a bit tricky. CMS, that's the Centers for Medicare and Medicaid Services, absolutely requires providers to use these codes. They call them HCPCS Level 1. But, and this is a big but, just because you code it doesn't mean you automatically get paid for it. CMS doesn't necessarily recognize or reimburse every single CPT code that the AMA approves. For example, CMS completely ignores CPT consultation codes. They just flat out don't cover them. On top of that, unlike the DRG system used for hospital stays, CPT codes aren't formally grouped together. Every single procedure kind of stands alone and has to prove its own worth.
Moving right along, Section 2, the math behind the code, calculating the price tag.
So instead of just slapping a flat dollar amount on a procedure, reimbursement is actually based on relative value units, or RVUs. Think of it like a recipe. Look at this pericardiocentesis code. That's a procedure to remove fluid from around the heart. It breaks down into very specific ingredients. The AMA says, okay, this requires 4.29 work RVUs, which covers the doctor's time, skill, and judgment. Then you add 0.83 practice expense RVUs for things like overhead and equipment, plus 0.99 malpractice RVUs for liability. Put all those ingredients together, and CPT 33016 is valued at exactly 6.11 total RVUs. And just for context, the work and malpractice amounts here are slightly less than average compared to everything else out there.
But hold on, there's a catch. A code's value isn't identical everywhere. Those RVU factors are actually adjusted by geographical location. The system knows that, hey, paying for clinic space and staff in New York City is way more expensive than in Oklahoma City, right? So the math automatically adjusts to reflect that reality. There is one really fascinating exception to all these grouping rules, though, and that's Maryland. Maryland is actually the only state in the whole country that is completely exempt from the DRG system. They operate under their own totally unique model.
Okay, let's turn this into actual dollars. We take our geographically adjusted RVUs, we'll stick with that 6.11 total for the pericardiocentesis. To get our final price tag, we multiply those RVUs by the Medicare conversion factor, which CMS sets every single year. For 2026, that conversion factor is $33.57 for qualifying alternative payment model participants. So let's do the math. 6.11 times $33.57 equals exactly $205.11. And boom, that is literally how the translation from human biology to standardized math gets finalized.
Up next, Section 3, who writes the rules? The bureaucratic maze.
Getting a new or revised code approved is quite the journey. First, it goes to the AMA's CPT editorial panel. This is an exclusive 21-member group that meets in person 3 times a year. You've got 12 members from national medical specialty societies, plus reps from major players like Blue Cross Blue Shield, the American Hospital Association, and private insurers. They even have folks from CMS, the CDC, and the FDA sitting in. Once that panel gives the green light, step 2 begins. It heads over to the RUC, the Relative Value Update Committee. They take input and assign those RVU values we just talked about. Finally, step 3, CMS reviews it, and most of the time, CMS just accepts the RUC's recommendations and makes it official.
Let's jump to Section 4, Bending the Rules with Modifiers, Adjusting for Reality. So modifiers are essentially the grammar that tweaks our coding language when reality throws a curveball and justifies increased reimbursement, because, things don't always go by the textbook. If a patient's morbid obesity means a standard procedure suddenly requires way more time and effort, the provider can just tack on Modifier 22 to their CPT code. Or, completely on the flip side, if a surgeon is operating on a tiny little infant weighing less than 4 kilograms, they use Modifier 63. These little 2-digit add-ons basically tell the payer, look, I did this standard code, but the patient's physical reality made it significantly harder. It is honestly a brilliant way to keep a standardized system while still allowing for the crazy variability of human health.
And finally, Section 5, 2 codes working together, the CABG climax.
All right, let's set the scene with a real-world hospital encounter. Imagine a patient is diagnosed with atherosclerotic heart disease without angina pectoris. They get admitted for an open coronary artery bypass graft, which you'll usually hear pronounced as a CABG, specifically on the left anterior descending artery. Now, to justify this massive surgery, both the hospital facility and the provider are going to use the exact same diagnosis code, ICD-10 CM code I25.10. But here is a super vital rule in coding guidelines. Diagnosis codes prove the medical necessity. They get you through the door. But they absolutely do not determine the payment amount itself.
That payment amount? That's driven entirely by the procedure codes, and this is where the systems dramatically split apart. For this one single patient encounter, the hospital and the surgeon bill in totally different ways. The facility reports an ICD-10 PCS code, grouping it into MS-DRG 236, and their payment for the room, equipment, and nursing staff comes out to a massive average of about $30,400. But the surgeon actually doing the bypass? They report our old friend the CPT code, specifically CPT 33510. Based on that RVU math we did earlier, the surgeon's payment is going to range from about $1,814 to $1,823, depending on location and modifiers. So you have 2 completely different code sets measuring 2 totally different things, working right alongside each other in the exact same operating room.
Which really leaves us with this one final thought. When you step back and look at the 11,520 CPT codes, those intense 21-member AMA panels, the geographic adjustments, the specific modifiers, and that huge split between facility and provider billing, if a single procedure requires 2 separate code sets and dozens of variables to calculate, is our healthcare language simply too complex? Or is it exactly as precise as it needs to be to capture the true reality of modern medicine? It's a wildly fascinating system, and I really hope this explainer helped you decode the journey. Keep learning, stay focused, and I'll see you in the next one.